Welcome everyone to the latest installment of EMS Focus, a collaborative federal webinar series. I'm Kate Elkins. I am an EMS and 911 specialist at the NHTSA Office of EMS. Together with our federal partners, NHTSA's Office of EMS is focused on advancing a national vision for EMS. The projects we undertake and the resulting resources for the community help with system improvements, measuring the health of EMS systems nationwide, and delivering the data that EMS leaders need to advance their individual systems. Another role of the office is to educate the EMS community on new innovations, processes, and technologies that can, in the end, help to provide better and more efficient patient care. This free webinar series, hosted by the NHTSA Office of EMS, is a unique opportunity for federal EMS agencies and industry experts to share information with the EMS community. EMS Focus conducts webinars several times throughout the year on issues that are important to the EMS community and provide you with timely information on what federal agencies are doing about them and what our state and local partners are doing that are innovative in our systems. Today's webinar is being recorded and will be archived on ems.gov for future viewing and listening. There will be time at the end of the webinar for questions, but please feel free to type questions or comments using the chat feature throughout the webinar. More information on the EMS Focus webinar series can be found on ems.gov. Next slide, please. In today's webinar, we will learn about the recent launch of 988, the new 3-digit dialing code for the 988 Suicide and Crisis Lifeline. People in crisis can call or text 988 and use the web chat available at 988lifeline.org to access compassionate care and support. We will also be discussing how EMS and 911 can collaborate with crisis response teams to improve the care and outcomes of patients experiencing behavioral or mental health distress. Next slide, please. Like I said, my name is Kate Elkins and I'm with the NHTSA Office of EMS. We will also be hearing from multiple panelists. Our panelists will talk about the importance of interagency collaboration. We'll be hearing from Richard McKeon from the Substance Abuse and Mental Health Service Administration. Next slide, please. We'll be hearing from Kimberly Bepnek of Gunnarson Valley Health, Jody Chin of Gunnarson Regional 911 Authority, Sean Cafferty of the National EMS Management Association, and Dan Gerard of the International Association of EMS Chiefs. Next slide, please. The Office of EMS mission is to reduce death and disability, to provide leadership and coordination for the EMS community, and really to help assess, plan, and develop resources to move forward with comprehensive evidence-based emergency medical services and 911 systems. Thank you so much for this opportunity to tell you a little bit about what our office has been doing in relation to supporting the launch of 988 and really crisis services and crisis resources across the country at the federal level. Since 2018, we have been participating in meetings with multiple federal agencies and with the event of the Hotline Improvement Act and all the evolution since then, all the way up to the launch of 988. We collaborate with the Federal Working Group on Suicide Prevention, the White House IPC for Suicide Prevention, and have been having regular meetings with the 988 implementation team from SAMHSA. Through collaborating with FCC, the VA, and SAMHSA, we tried to bring forward information that is relevant from the EMS and 911 communities and really help to connect the dots between our stakeholder communities and our federal partners who are doing this important and innovative work. Next slide, please. For those of you in the EMS community that don't know a lot about the National 911 program, I want to briefly bring up what the National 911 program is. It's housed in the Office of EMS, and it is a great resource for our 911 community as well as our EMS community. There are 3 jobs the National 911 program housed at NHTSA do. We pull together and convene all of our partners in the 911 stakeholder community. We help to build resources that states and local entities wouldn't be able to build on their own. All of this working to move us closer to an integrated system of systems of next generation 911 enabled systems that are interoperable across the country and provide the best care at the right time in the right place to every individual who calls for help. There are multiple resources on 911.gov that describe a lot of the projects that are done with the National 911 program. Approaching the launch of 988, the National 911 program has been very engaged to make sure that the 911 community and the 988 implementation team can overcome some of the challenges, be it technology, operations, education, and understanding, for interoperability between 988 and 911. It is equally critical for the EMS community to be engaged with their local and state entities working to implement 988 so that we can take and harness all the opportunities that these new resources for crisis and mental health care in our communities provide, and collaborate with those who are building this new and innovative approach to crisis care with additional resources in our communities. It is critical for all of our systems, the 911 systems, the EMS systems, who have been the safety net for years and years, to come together and understand how this new crisis system is evolving, how we can collaborate with these crisis systems, how we can educate them about our systems, and how we can work together to make sure that all of those in our community who need these important services have them available to them at the right time in the right place. So I'm going to introduce Dr. McKeon from SAMHSA, who's going to take over and explain a little bit of the evolution of 988. Next slide, please. Richard, check your microphone.
So I am glad to be with you today to talk about 988, its implications for the crisis system, the emergency system, and the implications for the future. This emergency medical services obviously have a critically important role to play in suicide prevention and behavioral health crisis services. So this past Saturday was the official launch of 988. And when we say that, what we mean is that that was the date by which the FCC had issued an order for the telecommunications industry that every landline, every cell phone, every voice over internet device needed to make 988 operational. And July 16th was the compliance date. So it's not as if it was an entirely new system turned on in that date. It was the date that everyone had to have it ready. And that's part of why there was so much attention paid to it this past weekend in all kinds of media that we're very grateful for, because we want to get the word out about 988. You can move to the next slide. So in the fall of 2021, after we knew that July 16, 2022 would be the deadline for everyone to make 988 available, SAMHSA had a number of critically important goals. The first and most important was to strengthen and to enhance the existing National Suicide Prevention Lifeline. So the National Suicide Prevention Lifeline has been around since 2005 and answered last year over 2 million calls. We are anticipating that number to go up significantly with the launch of 988, which is such an easier to remember number. So the most important thing for SAMHSA was to make sure that we were in a position where we could answer all the calls, all the chats, and all of the texts we were anticipating, because the FCC also ordered texting to 988 to be available and ready and operational by the same July 16, 2022 deadline. But strengthening the lifeline was not the only goal or the end point. When SAMHSA did its report under the Hotline Improvement Act to the FCC, in which we first recommended a 3-digit number, and said that we thought it could play a major transformational role in behavioral health crisis services in the United States in much the same way that 911 over a period of a half a century has played such an important role in improving emergency medical services across the country. So the goal of transforming and strengthening the broader crisis care continuum has been a priority since day one, although we know there's significant additional work needing to be done. So since the fall of 2021, we've been involved in various kinds of federal planning and convenings, working steadily on improving the operational readiness of the Lifeline network, developing resources for messaging and public communication, and laying that foundation for comprehensive crisis services. You go on to the next slide. So these are some of the key issues. So July 16th marked our country's transition to 988. So in many ways, it's a starting point, not an end point, because now we know that all across the country, you have an operating cell phone. If you have from your landline, from your voice over internet device, now 988 is working. And 988 offers 24/7 access to counselors trained in suicide prevention and behavioral health crises, and also represents an investment of unprecedented federal resources in scaling up crisis centers. Just a couple of years ago, actually just 4 years ago, the appropriation for the National Suicide Prevention Lifeline was $7 million. In President Biden's FY23 budget, that proposed amount is $696 million, so literally 100 times greater. And in terms of the resources that are currently available, there were $282 million that have already been invested in strengthening the network across the country, with an additional $150 million that was just provided through the firearm legislation that was recently signed into law. We are anticipating that there will be a substantial increase in the number of Lifeline calls, chats, and texts answered. We saw that in the first few days after the launch. But we are anticipating likely over the next year more than 7 million calls, chats, and texts. So a significant increase from previously. And that obviously is part of the reason for 988, is that it's an easier to remember number, and and that because of that, more people in crisis will access it. One thing that SAMHSA pointed out in our report to the FCC would be if a family member is experiencing chest pains, it is likely that despite the stress of that, both the person themselves and the family member with them, they're going to remember to call 911. However, if somebody was in the grips of a suicidal crisis, it was unlikely that they would remember the 10-digit number 1-800-273-8255. So we anticipate this 3-digit number will greatly increase call volume going into the existing system, and that system has been expanding. So we also believe that the long-term success of 988 really depends heavily on collaboration between states, territories, and the federal government, as well as with local communities all around the country. Next slide. So I said that in many ways, July 16th was the start and not the conclusion of these efforts. And that's because SAMHSA has a broader vision for behavioral health crisis services that we are working hard to try to implement. The idea is that we want to be able to have someone to talk to, someone to respond, and a safe place for help. This first horizon is around the crisis contact centers, is what we have been working on most intensely in preparation for the launch of 988. I should mention, of course, that not all suicide hotline calls, behavioral health crisis calls, will be going through 988. People will be making their own decisions about what numbers to call, and there, of course, will continue to exist other numbers. So you may well be contacted not only by the 988 centers in your community, but also by others. And it's important to be aware of that as well, whether it's a local community mental health center, whether it is another hotline. But one part of this vision is to make sure that there is access for everybody, someone to talk to. But the second horizon is someone to respond, the availability of mobile crisis services, so that in those instances where the issues cannot be resolved over the phone, and we think in many instances they can be, and appropriate referrals and linkages made over it, but there are going to be times when someone will need to respond. And we want to be able to have the availability of people trained in mental health crisis work to be able to respond. So we are working on promoting the availability of mobile crisis services across the country. And then the third horizon are stabilization services. Sometimes stabilization can take place with a mobile crisis visit, but also crisis receiving and stabilization units. Because not everybody needs to be brought to the emergency room. And we know that there are times, unfortunately, that people may need to wait in emergency rooms, not only for hours, but for days and at times even weeks. And crisis receiving stabilization services can be a very important alternative for that. Next slide. So SAMHSA's vision for crisis services includes these various components, provide individuals experiencing suicidal, mental health, and substance use crises and their loved ones with caring, accessible, and high quality support. To ensure integrated services are available across the crisis continuum, provide a health first response to behavioral health crises, and ensure connection with appropriate levels of care, to integrate lived experience of peers and support for populations at high risk for suicide, such as veterans, and the Press One option for veterans to be connected to the Veterans Crisis Line that has existed as part of the Lifeline through since 2007, remains currently operational for all those who call 988 or for those who call the 10-digit number. That 10-digit number, by the way, is not shut down. It still works, but we are now promoting 988. But we also know that LGBTQ populations, BIPOC populations, youth, and people in rural areas have specialized needs. And to advancing equitable access to crisis services for those populations at higher risk of suicide, including tribes and territories where there are higher rates of death by suicide, tragically. Next slide. So I mentioned that those three horizons. Well, those three horizons are part of what's called the Crisis Now model. And this is a model that SAMHSA has written about in our national guidelines for behavioral health crisis care. And the notion is a call center at the hub, as well as the availability of mobile crisis and crisis receiving and stabilization facilities. The idea that every community in America should have access to this. And you may wonder, why in the world is there an airplane on this slide? And the reason is, and we have referred to this as the Air Traffic Control Crisis Call Center Hub, to connect and ensure timely access and data. In other words, it's important that crisis services not be fragmented, that they're communicating with each other, and that someone is aware of what is the status of the person who's in intense crisis and is following that, including after the mobile crisis visit, including after the emergency room visit. And the air traffic control model points to the idea that when I flew here from Washington, D.C. to Denver yesterday, there was never a point in time where there was not an air traffic controller who didn't know where that airplane was and what the status was. What we are saying is that we think in the United States of America, it should be unacceptable for people to fall through the cracks of fragmented behavioral health crisis systems. And that is what we are aiming to enhance. Next slide. And the crisis call center is the hub of a system, can potentially have a number of additional components to it. Ideally, not everyone has this. We are trying to build it up, but the ability to dispatch mobile crisis teams. A number of states are doing this statewide now, including Georgia, Colorado, and elsewhere, Connecticut, and being able to track the location of those mobile teams via GPS, so that a team can go from one encounter to the next. The availability of bed registries, and SAMHSA has provided funding to states for the development of bed registries, because sometimes there can be incredibly long waits trying to identify a bed that is available. A bed registry can help with that. Ideally, a crisis call center hub can have the capacity to do outpatient scheduling. Georgia's been a real leader in this and have had for over a decade the capacity to, if somebody's in an emergency room at 2 in the morning or in a mobile crisis visit and an outpatient appointment is needed at any time of the day or night, the Georgia Crisis and Access Line can be contacted and the person can be given an appointment rather than be given a number and left to negotiate the system themselves. Next slide. And then again, the mobile crisis and community crisis partnerships is actually, we have a grant proposal for $10 million, a grant program. The funding opportunity will be closing in just a couple of days to try to promote mobile crisis programs that connect to other community partnerships, including emergency medical services, law enforcement, public safety answering points, etc. So mobile teams are incredibly important. Being able to meet individuals in the community to be able to provide assessments. There's no reason for someone to be transported to an emergency room, perhaps involuntarily, to obtain an evaluation that can be done in the community with the use of a mobile crisis team. Trying to help individuals to experience relief quickly, providing support while minimizing the use of law enforcement and ED use. I mentioned Georgia, Arizona, and Connecticut. There, of course, are some excellent co-responder models, and funding has been coming to mobile crisis teams in the last couple of years from new sources, including an 85% FMAP, which is a federal Medicaid match, and through SAMHSA's Mental Health Block Grant, where there is now a 5% crisis set aside, where mobile crisis is one of 4 allowable uses. Next slide. So I think it's also important for me to let you know that these centers answering the 988 calls have been thoroughly evaluated. We know that seriously suicidal individuals call the Lifeline, and that they are able to experience decreases in reports of intent to die, hopelessness, and psychological pain over the course of the call. That 55% of callers at imminent risk did not require emergency rescue by the end of the call. And those who did, about 19%, it was collaborative rather than involuntary. And then almost 90% of those who received follow-up calls, and we've tried to build in follow-up, felt that the calls helped them not kill themselves. Next slide. So SAMHSA has been working along with our partners at the FCC, at the VA, and at the Office of Emergency Medical Services with a wide range of external partners. And we are very much interested in ongoing work with those organizations involved with emergency medical services as well. Next slide. We have also been engaged in a significant number of activities on 988 and 911 coordination. In addition to the regular meetings with Kate's team at the Office of Emergency Medical Services, we've had calls with a variety of stakeholders. Through a co-sponsorship agreement, we developed called playbooks for states, for tribes, for behavioral health provider organizations, for crisis centers, and also for 911 public safety answering points. Our grantee that runs the Lifeline at Vibrant will be starting later this year, a community of practice. In June, we had a policy academy for 5 states, Maine, Georgia, Colorado, Minnesota, California, focusing on 988, 911 coordination. SAMHSA has provided grants to 48 of the 50 states, as well as several territories. And a required activity in there is to develop a plan on 988 and 911 coordination. We've incorporated this into crisis mapping activities, support in 30 different locations. We have been part of the National Emergency Number Association's 911 and 988 work group. And the CMS Digital Service recently did a deep dive for us around 988, 911 coordination to help us develop a long-term plan for continued improvement so that the coordination between 988 centers, 911 public safety answering points, emergency medical services, and law enforcement can be as coordinated and positive as it can be. Next slide. We have also developed a partner toolkit that's available on the SAMHSA website. We've been providing national level news media, and particularly over the last week, but even before that, engaging in webinars such as this one about 988. We work closely with state and local partners, and we also have launched what we're calling formative research with the Action Alliance for Suicide Prevention, really to look at groups at particularly high risk and what would be most helpful for them in terms of willingness to call and engage with 988. Next slide. And as I said, that this is a foundation for crisis services. There's additional support for mobile crisis through CMS. We've also launched a multi-channel tribal needs assessment, developed a 5-year vision for crisis services. We're partnering with the Office of the Assistant Secretary for Performance and Evaluation to develop an evaluation model. And we've expanded crisis services through an array of grant programs. Next slide.
Thank you, Richard. And now we are going to transition to Dan Gerard from the International Association of EMS Chiefs to tell us a little bit about his program and his community.
Great, thank you very much. And it's an honor and a pleasure to be here with everyone today. I'm Dan Gerard. I'm the EMS coordinator for a fire department in Northern California. That's an EMS provider, as well as the president of the International Association of EMS Chiefs. A little bit about my city and our population that we deal with. We are in the San Francisco Bay Area. We have a population of about 75,000 people. We do about 8,000 EMS calls per year. And we also have a community paramedic program. So our extension into the crisis response realm really made sense for us. At the same time, our local law enforcement organization was looking to transition out of crisis response for a variety of different reasons. They still respond for violent patients, but they wanted to move out of the day-to-day interactions. I would say that if you wanted to characterize my city, whether it was suburban, urban, etc., we would be using the geographic practice cost indicator. We would probably be classified as an urban center. And we staff our unit with 1 EMT and 1 paramedic. They have been provided training through the county public health agency through a contract that they have set up with another organization. And then we also have a licensed clinical social worker that's available to us. Our staff will liaise with them via telephone, and then the licensed clinical social worker can respond to the scene. Next slide, please. And so, when we look at this, and I want to apologize, on the left-hand side of the slide, that's supposed to be and that's my mistake. It's supposed to be 2020 to 2021. When we look prior to our institution of our crisis mobile unit, during the 1-month operational period that we looked at, we had about 48 calls during this period. About 25% of those responses resulted in transports, and all of those transports, except for like these small slivers that went to a shelter or to the BART station, everyone got essentially transported to a hospital or psychiatric facility. And about 38 clients total were involuntarily committed. When we fast forward a year later to the first month of operation of the crisis mobile unit, we had about 44 calls during this period. 27% of the responses were transports. But this is the interesting thing. When we say that those clients were transported, they were transported to places like Safeway to get food. We took them to more shelter and housing options. We took them to behavioral health care providers that were going to provide some at point of care counseling that they really didn't need to go to a psychiatric facility for. We took clients to Walgreens and CVS, and that's not a plug for any of those organizations, but to get their prescriptions filled. We addressed their baseline needs, and this was something that we learned from our community paramedic program. And then the other big issue was obviously making sure that they had shelter and housing. So we transported more patients there. When we look at it overall, prior to the institution of the care team, we had 38 clients that were involuntarily committed. Under the care team, we had 13 clients that were involuntarily committed in a 1-month time frame. And so, just if you were going to have some very simple models and benchmarks for success, I would say the fact that we reduced transports to hospital emergency departments and psychiatric facilities, overwhelmingly, I mean, we had, for the 1-month time frame, we had 0 responses went to the psychiatric facility by our crisis mobile unit. And when you look at patients that were involuntarily committed, I mean, we reduced that number, by almost 2/3. I would say that overall, the program is extremely successful. Let's talk about some of the challenges that we sort of run into. One of them was the training of our crisis response team. This was contracted out by the county, and it was essentially training that was specifically developed for licensed clinical social workers. And there was no real gap analysis or needs analysis that was completed. And so, some of the guys and gals felt that the training was really good, but it was better than what they got as paramedics. And some of the guys were, they weren't too keen on it. The other issue that I would say relevant to that is that some of the members on the crisis team, while they have performed exceptionally, they voiced concerns that they were still unsure of the performance algorithm that they needed to follow in the field. And again, that sort of falls back, I think, to the training that they received. And then the other thing was that we're about 6 months in, and one of the issues that has come up is that our members have voiced concern for emotional injury. We had one paramedic who withdrew from the program. We grossly underestimated the challenges both on a mental and emotional level for the responders. And so, now we're circling back and we're doing presentations weekly on vicarious trauma, giving individuals an opportunity to interact with the licensed clinical social worker and talk about the problems that they're facing. We're going to look at some type of battle buddy configuration at some point in the future, and this kind of transitions over into the needs analysis and the gap analysis. Next slide, please. So when we initiated our unit, the needs analysis, this was kind of thrown in our lap. The police department wanted to transition out, and the city council needed somebody to step in. And we were glad to step in, but we really didn't do a community needs analysis. And I would say to anybody that's starting a program is do a community needs analysis, because that's going to come back to not only the resources that you're going to need for the responses in your community, but also it's going to help you develop your educational program. One of the things that we found out, not only the lack of training, or the lack of a crosswalk between the training that was provided for licensed clinical social workers and the paramedics, was that on a very basic level, paramedics and EMTs really didn't get a lot of behavioral health education training. And we really didn't give much forethought to the people we selected for the program. Everyone volunteered for the program. They all, every member that, we talked about the program, we had extensive discussions, and they all stepped up. But I think going back, we would probably take a different approach. Next slide, please. So when we look at the gap analysis for EMT and paramedic education and licensed clinical social worker, before we sent our individuals for training for the community mental health response unit, when you look at it, there's really not a lot that's done there. And when I say that there's 3 to 4 hours of classroom instruction for a paramedic, when I say that there's 1 to 2 hours of classroom instruction for an EMT, that is what is recommended in many of the lesson plans that I have come across from different educational associations and groups. Nobody provides any clinical experience for EMTs or paramedics when they're going through their training. So if you get a crisis patient during your clinical encounter, that's just essentially by luck of the draw. As opposed to the licensed clinical social worker, they have 6 to 7 years of education and clinical rotations. Next slide, please. And so, when I talk about selection, when we talk about police officers, at one time I had a law enforcement position, and I remember that when I went for the position, I had to take two 500 question questionnaires that I had to submit, and then I had 2 panels that I had to sit in front of, and essentially that was to screen me out to see not only my emotional state stability, but also to determine my propensity, if there was a chance that I would develop psychiatric disorder, if I was at risk for substance abuse or addiction disorders. Psychiatrists, psychologists, licensed clinical social workers, they go through therapy. as part of their educational programs. We don't do any of this for EMTs and paramedics. Some organizations might do some limited psychological testing, but I don't think it's to the same degree that we do for police officers. And so moving forward, I think that this is going to be critically important for not only us, but for any organization that's looking to have people step up. The dynamic of the response is vastly different. We spend anywhere from 2 hours on a scene for a single patient up to 6 or 7 hours for one patient. Resilience is extremely important. What do we do for people after the call is over? How do we help them emotionally recover? How do we help them decompress? And these are all things that we're taking a deep dive on now currently. Training, I touched on a little bit. We really need a better model for training that encompasses some type of clinical component. So we need longer training. We need training that's specific to EMTs and paramedics, not this training that, well, the licensed clinical social workers have this training. We're going to invite you in. We need something that's designed for us based on our education or lack thereof moving forward. And then we also need to concentrate just on the base level EMS provider. They need a better training model and a better component, because patients that we're going to encounter more patients that have behavioral or mental health issues. And our training before was so sparse and so poorly performed. We really need to be better prepared moving forward. The operational issues I touched on, just ever so briefly, the fact that it takes 2 to 6 or 7 hours to take care, to help one patient. And that doesn't mean that the patients that are 7 hours, doesn't mean that they're transported to a facility, but sometimes there are many issues that need to be unpacked and dealt with. And then obviously at the end of the day, it's how do we finance the system moving forward? I can't use an in-service ambulance to respond to these calls and say, well, you're going to do crisis mobile response in between calls. It's just untenable. I have to have a dedicated unit. We learned this with our community paramedic unit in the very beginning. We have a dedicated unit for community paramedic. So how we finance the system moving forward in order to make it sustainable. And then the last thing that I want to say is I want to thank SAMHSA. You really stepped up here in a huge way. It took us 20 years to figure out, from the time they wrote the white paper in 1966 for EMS, it took us 20 years to figure out a trauma system of care. And you guys have really envisioned this through 988, crisis mobile response, and receiving facilities. You kind of gave us the package and a blueprint moving forward. So I really want to thank you for that. And that's it for me. I hope I didn't run over.
Thank you, Dan. And I just want to remind everybody, please enter your questions in the chat. If we run out of time for the questions, we will respond to all of them when we post on ems.gov at the end. And now I want to introduce Sean Cafferty of the National EMS Management Association, and he's going to introduce his team and the innovative work they're doing in Colorado.
Hi, everybody. Good afternoon. As mentioned, my name is Sean Cafferty, and in addition to being the current president of the National EMS Management Association, I have the privilege of being the Chief Executive Officer of the Crested Butte Fire Protection District, which is located in Gunnison County, Colorado, as my day job. And we are a combination department, and we have both paid employees and volunteers, and we are one of 2 ambulance providers in our county. In 2021, we found ourselves in a conversation about improving behavioral health response in our community. As a rural area, we have our share of behavioral health challenges, and Colorado overall actually has a pretty high incidence rate comparatively of behavioral health emergencies, and that's up to and including a fairly high suicide rate in comparison to other states. And as a community, we realized we could do a better job responding to mental health crisis. And how we really did this in our case was we pulled together our local response community. We engaged our critical access hospital and our local behavioral health experts to help us build what we now consider kind of a decentralized but highly coordinated crisis response model that has now been in operation for about a year. The key to our decentralized approach here is really that our providers all maintain their traditional roles, but we kind of coordinate our activities, and this integrated approach allows us to match resources essentially to the needs of our patient population and hopefully deliver care appropriate to the situation. We've also integrated this with the Colorado Crisis Services line, and that's one of what will be over 200 call centers that will be part of the 988 network moving forward. And my colleagues, Jody and Kimberly, are going to talk a bit more about that in a minute. As we tell the story of our journey, however, I just wanted to take a moment to orient you to Gunnison and Hinsdale counties in Colorado. These are not places you've probably heard of. And on this slide, you see an aerial photo of our rather not very large population center, the city of Gunnison. It's located along US Highway 50 on the western side of Colorado. We have a state college that you see in the foreground there. That's one of our major employers. And we are over 3 hours drive to the nearest metropolitan area and over 4 hours drive to our state capital in the city of Denver. Please advance the slide. This slide here just gives you a sense of kind of the large geographic area that our mobile crisis program covers. Gunnison County is orange in color, Hinsdale County is red in color. This area of the state is located in the Elk and San Juan mountain ranges of the Central Rockies, and is rather geographically isolated, and we have elevations ranging from 7,000 to 14,000 feet above sea level in our area. And on to the next slide, please. In terms of scope and capability, you can see our two counties encompass a large area of around 4,500 square miles. We have a total resident population of only about 18,000 people. Tourism, outdoor recreation, higher education, government services, and agriculture, primarily ranching, are our primary economic drivers. From an emergency services perspective, we have one 25-bed critical access hospital that serves our area. In addition to the hospital itself, our local health system also supports outpatient care, includes family practice, operates the only long-term care facility in our area, and also operates a hospital-based EMS service, Gunnison Paramedics, that is our largest provider. Our nearest large hospitals and inpatient behavioral health facilities are well over 100 miles away. Our nearest walk-in crisis facility is about an hour and a half away. From a response perspective, Jody is the executive director of our 911 dispatch center and public safety answering point. It serves 2 counties as well as portions of a third. We have a half a dozen law enforcement agencies in our area, including 2 sheriff's offices, 3 municipal police departments, and a large area actually covered by law enforcement from the National Park Service. We have 4 fire agencies, only one of which provides ambulance service, and then 2 additional independent ambulance providers, 1 hospital-based and 1 county-based. Currently, none of our EMS providers have a community paramedic program or anything along those lines. So as we tell you about our program, the punchline is pretty straightforward. We have a lot of geography. We are quite limited in terms of capacity, but we have a cooperative spirit, and that was the starting point as we built our program. And with that, I will turn it over to Jody.
Thanks, Sean. As Sean said, my name is Jody. I am the executive director of the Gunnison Hinsdale 911 Authority. And so I want to talk a little bit about how we got our mobile crisis program. The first, obviously, is that these calls tend to start in the 911 center. So we noticed in a 3 to 5 year gap that we had an increase in mental health crisis calls, and the pandemic only served to enhance the fact that we had a lack of resources in our area for our mental health crisis callers and patients. The lack of resources, the picture you see there is Gunnison Valley Hospital, our critical access hospital, also the only hospital for us within 80 miles. We had one outpatient facility which was not assisting us with patients in crisis, but more of a make an appointment kind of walk-in facility that you had to kind of wait weeks for. We also had a lack of training for both of our 911 dispatchers and our EMS personnel in recognizing and caring for those having behavioral health crisis. We've all had the suicidal caller training, the excited delirium and all of that, but we weren't really dialed in on what our behavioral health care should look like. So all of this combined served for our community to recognize that we had an issue that we needed to take care of, and we didn't have any outside resources or close resources like a crisis facility, an acute bed system that we could call upon to help us with. Next slide, please. The biggest problem we had was a failure to provide timely and acute crisis intervention. So when we would have these patients in mental health crisis, a lot of times they would end up in our jail or they would end up in our emergency room. And so then they would sit there for days, hours or days, waiting for a telehealth appointment or a crisis counselor to come from another region to provide them with some sort of assessment and intervention. This put our law enforcement officers and our EMS crews out with these patients for an extended period of time. And for those of you who work in rural areas, you know that that's a precious commodity is your officers and your ambulances, right? And so we really had no way to urgently treat these patients in crisis. With that, there became a big push with the law enforcement agencies to no longer be able to place these patients in the jail unless they had criminal charges. So then they began to flood our emergency room. We had nowhere else to treat them, and so they all ended up in our critical access 25-bed hospital. Once they were treated by the telehealth or the regional provider, then they would be discharged back to wherever they came from. A lot of times that was, in the homeless population, back to family that couldn't assist them. And within hours or days, they were making another 911 call and they were right back into our system. And the cycle just continued to repeat over and over. And then came the change in public expectation around public safety response to those in a mental health crisis. It was no longer really acceptable to place them in jail. It was no longer really acceptable to chemically restrain them and haul them to a hospital, racking up charges and cost to them when they were having a behavioral health emergency. Next slide, please. So we started a group of our mental health professionals and our first responder agencies to kind of discuss where we needed to go in terms of how we were going to help those experiencing a mental health crisis. The biggest person that it was impacting, or the biggest agency, was Gunnison Valley Health. And so they kind of took the lead on all of this and decided that they were going to pull the trigger on overseeing a mental health system within our emergency response system. So they started their behavioral health department. They hired Kimberly Buhonic, who you'll hear from next, to be their director. That brought together meetings between the behavioral health professionals, Gunnison Valley Health, our law enforcement partners, EMS, and then our 911 communications center to determine the best solution for caring for those in our community who were experiencing a mental health crisis. And we determined after all of those meetings that we needed someone to go to the scene. And that was the biggest piece for us, is we needed an acute treatment for these patients at the scene, not later on in an ER or in a jail, and that we could utilize someone who had the training to handle this type of crisis. So with our brainstorming sessions, we talked about what we wanted the response to look like, which was eventually they need to come to us where the patient is. Funding options, which included grants, funding through our partners in law enforcement, EMS, our municipals, our counties, as well as our state operations for mental health, Rocky Mountain Health Plans. We discussed interoperability, what each person's role on the scene would be, and what that looked like so that we were cohesive in how we were treating these patients. And we also discussed training, and that was not only training for the 911 center and our EMS and law enforcement personnel, but training on how to work together. Next slide, please. So the 911 authority's role in all of this is we ended up creating the policy and procedure on how mobile crisis would work within our emergency system. We reevaluated how we handled our incoming mental health calls, and we realized that we were underutilizing a service that was already in place, which is the Colorado Crisis Services line, which will be the main line that 988 for Colorado will go into. And so with that, we created a policy and a procedure on what types of calls we would take from the 911 call and push over to the Colorado Crisis Services line. With that, they also developed our mobile crisis dispatch and how we would handle our mobile crisis technicians going out to the scene, whether it was a co-response or alone. And then the use of the mobile crisis response team in policing EMS incidents, our policy and procedures created the different types of encounters we might have where we might utilize both mobile crisis and law enforcement or EMS response to determine the best outcome for the patient. So with that, GVH Mobile Crisis then became a user agency with our 911 authority. And the best part that has happened for that is we dispatch them as we would any other emergency service agency. They are not their own entity. They are integrated into our public health or our public safety system. And we handle them just like we would any call for service. And that, I believe, has been the easiest part of handling these mental health crises, is that we have someone 24/7 that can come out and assist with this, whether it's at the request of police, EMS, Colorado Crisis Services, or 988, or the use of other behavioral health providers in the community. Next slide, please. So with that, I'm going to pass it off to Kimberly Bohonic. She's the Director of Behavioral Health for Gunnison Valley Health, and she's going to speak a little more to our system.
Well, thank you for having me today. We spoke to why we started already, that we wanted a locally operated provider and that actually sent a staff to scene. We've done all the integration that Jody spoke to. Everybody knows their scope of practice to have the best outcome for the patient, and we don't have any turf wars on scene. We will debrief after a scene to kind of just figure out some of the nuances that came up that we couldn't train and prepare for in advance. We do send a master's level clinician, or we can get a waiver from the state of Colorado for someone in a master's program for behavioral health 1 year in, so they can work for 12 months before graduating with a master's degree. Next slide, please. If we need a mental health transport, or what in Colorado is called as an M.5 or an involuntary M1 hold on scene, right now we either utilize our law enforcement officers that are co-responding, or I am the licensed provider that backs up my clinical staff and comes to the scene. As indicated earlier in the presentation, GVH saw a 200% increase in 2019 and 2020 in behavioral health admissions to the emergency room. It is the only 24-hour facility, our critical access emergency room, in the two-county catchment area that we serve, Gunnison and Hinsdale County. What would happen is they would wait an average of 2 to 6 hours to see a telehealth provider for a behavioral health assessment. The client would be frustrated, sometimes leave against medical advice, putting physicians and nurses at risk. They would have a large emergency department visit bill, and then they would have no connection to local services, which just resulted, as Jody referenced earlier, in repeat calls to 911. Next slide, please. This is our data from July 1 of 2021 to June 30 of 2022, our fiscal year for our funding sources. And we had a total of 143 assessments, 13 other calls that were canceled for various reasons, but none because mobile crisis denied coming to scene. So we're pretty proud of that. 78% of those 143 assessments occurred without EMS professionals on scene. 36% in our first year occurred without law enforcement on scene. Again, data that I'm pretty proud of. 80% of those assessments were safety planned. Sorry, that's a typo in the slide. Safety planned and stayed in our community. 0.14% went to our emergency room. So the data demonstrates that emergency room visits weren't necessary in the majority of these calls, which is the whole purpose, as everyone on this call to date has talked about, keeping people out of unnecessary levels of care. Next slide, please. So we were asked, when approached to do this by Kate and team, to come up with an incident, talk about an outcome and some lessons learned. So 911 had a call to a local hotel room for a female with prior refusal of medical care via EMS, with the chief complaint of, I'm going to die, God knows why and how, and I have stomach cancer. Would refuse to leave hotel room, didn't work, had food delivered on a regular basis, and a room paid for monthly. Denials to allow access to her room in many situations meant no action was taken. But again, those 911 calls just kept consistently coming. We learned on scene that the patient wasn't letting hotel staff into the room to change linen or towels. And mobile crisis was able to observe over the course of several calls that the patient was losing weight between mobile crisis contacts. So our final contact with this individual and outcome was we utilized a female law enforcement officer that had a relationship with the patient. That female officer was able to coach the patient out of the room while mobile crisis clinicians were listening for possible reasons to do an M.5 transport. We are also trying to rule out evidence of substance use, as I'm sure you all know. Inpatient psychiatric care has to be last on the list, rule out medical, rule out substance use, and then if symptoms are still present for SI, HI, or grave disability, then we can start looking at a higher level of inpatient psychiatric care. So we did place the patient on an M.5 with EMS and transported to our local emergency department. We anticipated the patient would refuse the labs. We did go ahead and place the patient on a mental health hold and secured placement without labs, which is pretty atypical, but we had enough information to support that and able to gain that grave disability status and have the patient receive inpatient care. Some of the lessons learned was the patient said to a male EMS worker as they're about to get on the ambulance, you're going to rape me if I get into the ambulance, and other graphic things. So therefore, the clinician rode along in the ambulance for safety, just to have that second person in the back that had that training that Dan was talking about, the behavioral health specific years of training. And when we arrived, we realized that EMS worker had called our emergency department for abdominal pain. You know, going back to that stomach cancer medical reason on why am I here as an EMS worker on this call. The clinician, then the mobile crisis clinician, was able to give the nurse from the ambulance information about the M.5 to get a ligature-resistant room prepped versus a non-ligature-resistant room, which was where they were taking the patient. That obviously could have had a poor outcome. And then we were able to follow up with our EMS captain for some more education. And we acknowledged as mobile crisis clinician on scene, we just need to communicate more with the EMS worker riding with the patient versus the one who drove. There was like a little shift at the end of the call we weren't prepared for of the EMS workers kind of shifting roles. Next slide, please. Here's some impact statements from Rob Weisenbaum, our chief at Crested Butte Fire Protection District, about the impact. And due to time, we'll go to next slide, please. And CJ Malcolm, our GDH EMS chief, who I thought it was pretty awesome that he said provides a rapid and safe intervention, and they can't imagine what it's like working without this service now. So next slide, please. And that's it. Now I'll kick it back to Kate.
Thank you so much, and thank you to everybody who has stayed with us. I know that we are over time. You have submitted so many fabulous questions. We will work with the teams who presented today to get answers to your questions. We will make sure that all of the slides that are posted, you can see all the parts of the slides when we post them on ems.gov. We can easily do another installment in the future if this is of interest, if you want more information. Up on the slide right now, you have the contact information for all of those who presented. This will be included in the deck when it gets posted on ems.gov. We really appreciate everybody taking the time to be here. We appreciate all of our speakers. So please consider submitting questions before we close out the webinar. If you did not get an opportunity and you have a question that you realize later, you can email your question to the NHTSA EMS email address. And we really appreciate everybody taking the time to attend our webinar today. Thank you to all of our speakers.